Hello, my name is Om Patel, and today we'll be talking about one of the most impactful and oldest infectious diseases known to humankind, which is tuberculosis, or it's also known as TB. Um, the disease still affects millions of people worldwide today, and over the next 10 minutes, we're going to talk about the pathophysiology of TB, how it spreads, it manifests in the body, and like the certain systems that it impacts, and how we diagnose, and why it's still a public health priority to this day. So to be more specific, we're going to cover the pathogenesis and clinical symptoms that are presented with TB, the epidemiology and the importance of understanding where regions are most affected by TB, and the systemic effects of tuberculosis on the respiratory system, the gastrointestinal system, and the central nervous system. Also, this overview isn't specifically in that order. We're going to do the pathogenesis first, and then the systemic effects, and then the epidemiology. I just couldn't change the bullet points for some reason, so yeah, bear with me. What is tuberculosis? So, TB is a chronic infectious disease caused by a bacterium called Mycobacterium tuberculosis, and it mainly affects the lungs, but it can spread to other parts of the body easily. It spreads through cough-generated aerosols that are tiny droplets that are released when people talk or people with TB talk, and you're in close proximity with them, and the person can breathe in, and that's how it enters our bodies. But once they're in the lungs, the bacteria are picked up by our immune cells called alveolar macrophages, which are macrophages are our first line of defense in innate immunity, and alveolar is basically tell you where the location is, so they're in our alveoli within our lungs. And I want to tell you guys about this figure right here, figure 1. It shows a basic look at how the immune system responds to TB. So when the bacteria enter the lungs, they're picked up by those alveolar macrophages, which is our first line of defense. The macrophages then signal to helper T cells. Let me see if I can get my laser pointer. Perfect. So the macrophages signal to the T helper cells, which then release a chemical called interferon gamma, which is right here. And this helps, the interferon gamma helps activate more macrophages to kill the bacteria. And at the same time, other immune cells are also called in or signaled and try to help. And together, they all form a granuloma, which is basically like a protective barrier or somewhat more of like a jail cell for the infection. So the whole point of those immune cells is try to trap that infection. And inside the wall, the dead cells can form a center called a caseous necrosis, which can also eventually lead to cavitation, which isn't good, which is basically a perforated hole within your lung, and that also allows for more Mycobacterium tuberculosis to enter the bloodstream as well, and that's how we're gonna get to CNS tuberculosis as well. And the cavitations can lead to like sputum culture, which is your phlegm, drug resistance, which isn't good for or when it comes to treating tuberculosis, and transmission of infection to other people. That's why tuberculosis, like ability to like hide in the body and come back later, makes it very hard to control, and that's also why it's still one of the world's deadliest infectious diseases today. So this slide talks about the symptoms and some of the pathophysiology of respiratory tuberculosis. So just to list them off, some symptoms are weight loss, fever, which is our immune response, loss of appetite, breathlessness, and pale appearance. Other symptoms also include cough, sputum, which is our phlegm. The phlegm could also be tested for active TB as well. Fatigue is also one, hoarseness, and blood spitting, which I think I read, blood spitting is also, it's kind of rare to see patients have that symptom with TB. I also wanted to give a quick shout out and mention to Dr. Naklev in his respiratory notes for our class. I read that I thought it was important to mention that cortisone shouldn't be given to patients with tuberculosis because the drug can suppress the immune response, which isn't good at all if you have tuberculosis, and it can lead to even further complications and symptoms. And I just thought it was very important because I couldn't find that anywhere else in any articles, and I had it in Dr. Naka's notes, so I thought I should give it a shout out. And going into like the pathophysiology of what's going on in respiratory tuberculosis. So the myobacterium, it damages the lung tissue through the immune-driven inflammation and those and the enzymes called matrix metalloproteinase, which is also known as MMPs. They help break down the collagen and the lung structure support, which can lead to further tissue destruction and fibrosis. The scarring stiffens the lungs and reduces their ability to expand, causing breathing difficulties. I didn't put this on the slide, but the study that I cited for respiratory tuberculosis, like the information on the slide, it talked about the use of doxycycline. That's what they were studying as well. It's an FDA-approved drug. It's an FDA-approved MMP inhibitor for the enzyme, and that could help by like protecting the lung tissue and slowing bacterial growth in vitro as well. They tested it in vitro and they saw that it helped with patients with TB, and so it could be a potential low-cost adjunct to standard TB treatment. The thing is that children can't use doxycycline because it can lead to side effects. So we just finished talking about the respiratory TB, and now we're going to switch to gastrointestinal TB. So gastrointestinal TB can affect any parts of the digestive system, but it most commonly targets the peritoneum and the ileocecal area, which is shown in figure 4 right here. These sites are more vulnerable because they have more lymphatic tissue, slower movement for digestion, and higher absorption rates, which creates an ideal environment for bacteria. There are 4 main ways TB reaches the gut: through the bloodstream from lung infections, as we were talking about the perforations. It could also reach the gut by swallowing infected sputum, which is our infected phlegm, by eating contaminated food or milk, or by directly spreading from nearby infected organs as well. Once the bacteria enters the gut lining, they trigger granuloma formation, inflammation, and thickening of the tissues. Depending on the extent, GI TB can appear as ulcers, hypertrophic, which is thickened tissue, a combination of both, which is, I think it's called ulcerative hypertrophic. Yes, ulcer hypertrophic, and also fibrotic scarring. The most common problem caused by GI TB is intestinal blockage due to the thickening of the intestinal lumen, the hypertrophic aspect, and this can further lead to symptoms such as weight loss, loss of appetite, and abdominal pain. And lastly, of the systemic effects, we're going to talk about central nervous system TB. So central nervous system TB begins the same as respiratory TB, as I mentioned earlier, where myobacterium tuberculosis spreads through inhaled droplets. It reaches the lungs and triggers an immune response, forming granulomas. The difference is that they spread silently in the bloodstream and travel to oxygen-rich areas, primarily such as the brain. Inside the CNS, small infectious sites called rich foci develop and can stay dormant for months or years before reactivating. And if the tuberculosis ruptures into the fluid subarachnoid space, which is in between the pia and the dura mater, they can cause meningitis, and if they grow deeper within the brain or spinal cord tissue, they can form tuberculomas, or more rarely abscesses. Massive inflammation is going to follow from the infections and can lead to vasculitis, which is what blocks blood vessels and causes things like stroke. It can also obstruct the cerebrospinal fluid flow and result in hydrocephalus from the increased pressure in the brain. Additionally, surrounding brain tissue can be damaged, causing conditions like border zone encephalitis or distant white matter damage, which is also known as leukoencephalopathy and can lead to problems in motor function and coordination. Children are also particularly at risk and often show earlier and more obvious signs of CNS TB involvement compared to adults. I think I'm past 10 minutes, but I wanted to incorporate the epidemiology and importance of understanding tuberculosis because I'm a firm believer in that health is the most important thing we should try our best in taking care of and understanding its importance in our lives. So even with modern age advances in medicine, TB is far from eradicated globally. It continues to be a major health burden, particularly in regions with limited healthcare infrastructure. So even in the U.S., TB persists in vulnerable populations, and understanding the epidemiology is key for effective public health intervention. I included this figure right here. I know it says figure 3, but it should say the last figure. It's basically just a map of showing parts of where TB is very prevalent, and you can see on the map, let me get my laser pointer out. You can see on the map that the middle and southern parts of Africa and a lot of Southeast Asia still deal with many cases of TB, and they should try and put more emphasis on eradicating the disease entirely. And I know I say that, and I know there are challenges many of these countries face when it comes to resources, but as a world, we should work together and help as many people when it comes to public health. Because then again, it's, in my opinion, health is one of the most important things we should try our best in taking care of. Here are the references I used for the presentation, and thank you so much for listening. I hope you understand the importance of certain diseases and make sure we try our best not to catch them. Thank you so much for your time.